Assalamu alaikum wa rahmatullahi wa barakatuh. Let's continue the topic of arrhythmias from where we have left. So, yesterday we have discussed about supraventricular tachycardias, including atrial fibrillation, atrial flutter, their ECGs. Today we will discuss about ventricular arrhythmias and bradyarrhythmias. So, ventricular arrhythmias originate from the ventricles. They originate from the ventricles. So, number one, they can be in the form of ventricular premature beats, VPCs, ventricular premature contractions, or PVCs, premature ventricular contractions, also known as. These PVCs can be monomorphic or polymorphic, meaning they can be of single morphology or they can be of different morphology depending upon the foci which is firing, and they can be single or they can be complex, single or multiple. Okay, see, this is the normal sinus ECG, and here the arrow which points, these are nothing but VPCs. These are not preceded by any P wave. Okay, so these are nothing but ectopic premature ventricular contractions, and these are, you see, these are followed by this is nothing but this after the PVCs which you are seeing, this one and this one. These all are nothing but pauses which follow the VPCs. That is the characteristic of VPCs. So there will be a VPC and it is followed by a pause. Okay, this is simultaneous arterial pressure recording. You can see here when there is VPC, the ventricles are not filled properly, so the beat is not that strong, but the following beat is very much strong, because ventricles will get time during the pause phase and they will fill more with blood, and contraction will be stronger than the previous beat, that is called as a thump beat. Okay, so these VPCs are broad bizarre QRS complexes with no preceding P waves in between normal sinus beats. Their configuration varies, so these are multifocal ectopics because there are morphologies that this VPC has different morphology from this one and this one and this one. Okay, a simultaneous atrial pressure. This is the ectopic beats result in a weaker pulse, which may be perceived as a dropped beat. This one, this is this is perceived as a dropped beat. Okay, because the ventricles are not filled properly with blood. Okay, some other example. Here you can see, this is from Oxford. This is the VPC and this is the expiratory, this is the pause following a VPC. Okay, there is no retrograde atrial activation occurs and the P wave sequence is undisturbed. Well, there is no circuit activity, just there is ectopic beats in between normal sinus beats. See, this is normal P wave followed by QRS complex, normal P wave followed by QRS complex. Okay, normal P wave followed by QRS complex. That's about ventricular premature contractions. And remember, they can be monomorphic. And in monomorphic, you remember, these disappear after exertion. Just say the patient to walk. After walking, you take one more ECG. If the number of VPCs reduce in the ECG after walking, then those VPCs are benign, considered as benign. If these reduce, if they don't reduce, then they are not benign. 2D echo should be done. Okay, they are not benign. That is one thing. And second type of VPC is polymorphic VPC, and polymorphic VPC should always be evaluated by 2D echo. Polymorphic VPC, as well as one more, if the number of VPCs is more than 8 to 10 VPCs in one ECG, 8 to 10, more than 8 to 10 VPCs, whether it may be monomorphic or polymorphic, if they are more than 8 to 10 VPCs, then that's the patient should undergo 2D echo. Okay, these points are important, just to remember. Second is ventricular tachycardia, very important. This is a life-threatening emergency. So it can be sustained ventricular tachycardia and non-sustained ventricular. Non-sustained ventricular tachycardia lasts less than 30 seconds without any hemodynamic compromise. Whereas sustained ventricular tachycardia lasts more than 30 seconds, or it causes hemodynamic compromise. What is, whether it can be hypotension or it can be altered sensorium. Okay, these are the signs of hemodynamic compromise. You can see here, this is a non-sustained ventricular tachycardia. You can see broad QRS complexes. Okay, broad QRS complexes, but these got subsided in less than 30 seconds. That's why it is non-sustained ventricular tachycardia. Okay, you can also see P waves here. These are P waves. This one, this one, this one. Okay, this submerged in the QRS complex. Okay, next, coming to the sustained ventricular tachycardia, you can see here there are 3 examples. This is an example of sustained monomorphic ventricular tachycardia. This is first example. Now, A1 is example of monomorphic ventricular, because all the QRS complexes, these are all QRS complexes. They are of same morphology, broad QRS complexes, and the rate is more than 100 beats per minute. And you can also note the P waves. Here one P wave, here one P wave, here one P wave, here one P wave. Okay, so that's about ventricular tachycardia. Okay, and one more thing to point out here is ventricular tachycardia with atrioventricular dissociation. P waves are seen to have no relationship to the ventricular activation. That is lead V1. This is nothing but lead V1. There are some hallmark features of ventricular tachycardia. One among that is AV dissociation. Second you can take is if you find some capture beats. Third is fusion beats. So these are the features which you find in ventricular tachycardia. In AV dissociation, what happens? Atria will beat on their own pace, ventricles will beat on their own pace. So atria will have some heart rate and ventricles will have some ventricular rate is different from atrial rate. Okay, ventricular rate is different from atrial rate, and ventricular rate is more than the atrial rate. That is the characteristic feature of ventricular rate is more than atrial rate. That is ventricular tachycardia. You can see here, if you measure, this is the P wave, this P wave, this one P wave. See the interval. See the interval in between this P waves. This is same. So the interval between P waves is same, and this is one QRS complex. This is one QRS complex. This is one QRS complex. This is one QRS. So this interval between the different QRS complexes is same. So ventricles are beating at their own pace and atria are beating at their own pace. So that is AV dissociation. Okay, that is a characteristic feature of, and ventricular rate will be more than the atrial rate. So that is ventricular tachycardia. That is, this is first A, diagram A shows ventricular tachycardia. This shows AV dissociation. Okay, AV dissociation. Now in B, ventricular tachycardia with fusion beat. What is fusion beat? Fusion beat is nothing but a normal impulse coming from the AV node fuses with the ectopic impulse from the ventricles. So though both combine to form a different QRS complex, that is considered as fusion beat. Okay, so if this is SA node, this is AV node, this is bundle of His, this is Purkinje fiber, and this is some ventricular ectopic site. So the normal impulse which comes to activate the ventricle will fuse with this, and this will produce a QRS complex which is different from the VT, ventricular tachycardia QRS complexes. That is seen here. See here, see the morphology of this QRS complex. See this QRS complex, see this QRS complex, see this QRS complex. See, all these are of same morphology, but this one is different morphology. Okay, different morphology. So this is known as fusion beat. Okay, fusion beat or capture beat, both are same. Fusion beat or capture beat. Now the third figure is a ventricular tachycardia with 2:1 ventriculo-atrial conduction. Lead 3. P waves follow every second ventricular conduction. So here the impulse is traveling back from the ventricle to the atria. Ventricle, every second ventricular impulse is carried to the atrium. So that 2:1 conduction is seen in this third ECG. You can see this is first P wave, which is not normal P wave. Okay, abnormal morphology, and this is one QRS complex. Not seeing any, you are not seeing any P wave here. Again here one QRS complex. Now you are seeing here. Again you are not seeing any P wave here. Again in the after the second QRS complex you are seeing the P wave. Again here you are not seeing any P wave. Again after the second QRS complex you are seeing the P wave. So every after second QRS complex you are seeing an abnormal morphology P wave. So that is 2:1 ventriculo-atrial conduction in ventricular tachycardia. So this is the example of monomorphic ventricular tachycardia. This is AV dissociation, this is fusion beat, and this is 2:1 condition, ventriculo-atrial conduction. Okay, that is the ECG of ventricular. This is one more ECG you can see here. So you should see lead 3 and lead V1. Okay, see the lead 3 wisdom strip. So these are all QRS complexes, wide QRS complexes. Okay, and in this you can see this one. See, these arrows point toward P wave, which is submerged in the QRS complexes. There are typically very broad QRS complexes and marked left axis deviation. See, so left leaves. This is in lead 3 it is towards downside, and in lead 1 it is upside. So left leaves, this is the mnemonic, no? Remember, left leaves is nothing but left bundle branch proc. Okay, so there is left axis deviation. Okay, left axis deviation, not left. Okay, commonly seen in left bundle branch block. There is also atrioventricular dissociation. Yes, because atria are beating at their own pace and ventricles are beating at their own pace. Ventricle by QRS complexes you can see, and arrow represent the P waves. Some P waves are visible and others are buried in the QRS complexes, and they see the distance between these two p waves, it is same. Okay, and you cannot see any capture beat here, capture beat, fusion beat. So AB dissociation is the very common thing which you find in ventricular tachycardia. Here I think you can see a capture beat or fusion beat. In ventricular tachycardia, there is independent atrial ventricular activity. Occasionally, a PAV is conducted to the ventricles through the AV node, as I explained, producing a normal sinus beat in the middle of the tachycardia, capture beat. More commonly, however, the conducted impulses fuses with an impulse from the tachycardia, fusion beat. This can occur only when there is atrioventricular dissociation, and therefore it is diagnostic of ventricular tachycardia. So this is an example again of fusion beat. Okay, it is an example of fusion beat. So this can happen only when there is AV dissociation. So it is different from other QRS complexes. You can see here other QRS complexes, and this is the P wave, P wave, P wave. See AV dissociation, P wave, P wave. This is R wave, R wave, R wave. Okay, remember AV dissociation. Next, coming to the ventricular fibrillation. What is ventricular fibrillation? Disorganized ventricular activation, a terminal rhythm without effective cardiac output. Just the similar to the atrial fibrillation, where the atria just they shiver, they don't contract. Similar to that, ventricles also just shiver. So a shivering ventricle can't give an cardiac output, and it can lead to a sudden cardiac death. Okay, it is a rhythm of death. Remember, ventricular fibrillation is not, and ventricular tachycardia can break into ventricular fibrillation. That's why it is an emergency. Okay, this is an example of ventricular fibrillation complicating acute myocardial infarction. The arrhythmia is initiated by an R on T ventricular extrasystole. This is known as R on T phenomena. R and T phenomena. Okay, R on T phenomena. This causes ventricular fibrillation. We can see here, this is ST segment elevation. Here, this is the P wave, this is the P wave, this is the P wave, this is the P wave. Okay, this is ST segment elevation, this is ST segment elevation. So there is a MI, there is a MI, there is a MI, but when during this should be followed by a T wave. No, here should be the T wave, but at that time there is some extra systole which is impinging on this T wave, extra systole which is impinging on this T wave. Nothing but when the ischemic myocardium is repolarizing, at that time a ectopic beat comes to the ischemic myocardium, and that produces this atrial fibrillation. See, it is just fibrillating here. This is known as R on T phenomena. T is nothing but repolarization of ventricles. R is nothing but depolarization. So an premature impulse is coming during repolarization of ischemic myocardium. That R on T phenomena produce a arrhythmia. That is nothing but ventricular fibrillation here. R and T phenomena is very dangerous thing which is happening. Okay, that's about ventricular fibrillation. One more thing you remember. When VT is called when the premature ventricular contractions are more than or equal to 3, and they should be in simultaneous. What is the definition of VT? VT is nothing but, so this is three wide QRS complexes you are saying, no? So at least, and consequently they are consequent, they are not in between normal sinus beats. So more than 3 PVCs is considered as ventricular tachycardia, and then it can be sustained and non-sustained. Okay, coming to bradyarrhythmias. So in bradyarrhythmias, heart rate is less than 60 beats per minute. Okay, just there are two things which cause bradyarrhythmias. Number one is sinus node dysfunction. Number two is AV block. Sinus node dysfunction and AV block. So sinus node dysfunction is also known as sick sinus syndrome. What happens in this? There is inappropriate sinus bradycardia. The sinus is sick, okay, and sometimes it can cause pauses. Sometimes the sinus will cease to discharge, arrest. Sometimes the sinus beats more and less, more and less, more and less. That is tachybrady syndrome, okay. So anything can happen in sick sinus syndrome, and if the patient collapses due to this sick sinus syndrome, that is known as Stokes-Adams attack. Stokes-Adams attack due to decreased cardiac output. So sinus node ceases to fire for some seconds. So due to that, there is reduced cardiac output and the patient will collapse to the ground. That is known as Stokes-Adams attack. Okay, that is a feature of sick sinus syndrome. Now coming to the AV block. AV block can be first degree, second degree, and third degree. Second degree include again it include type 1 Mobitz type and type 2 wenkebach type. Okay, so first degree AV block is, so AV block is nothing but if this is SA node, this is AV node, this is bundle of his, this is right and left bundle. Okay, so here this is AV node, no, okay. Here there is block, and that block is nothing but the resistance to the impulses which are going to the ventricles. So as the resistance increases, the blocks, the degree of block, it will go progress from first to second to third. Okay, we will see that in first degree AV block there is prolonged PR interval more than 200 milliseconds, or you can say more than 5 small squares. More than 5 small squares is considered as prolonged PR interval. What happens in this is all P waves are conducted and just there is prolonged PR interval. You can see here, if you count the box, small boxes, they are more than 5. 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 Okay. And there is no dropped beat here, no dropped QRS complex, just there is prolonged PR interval, prolonged PR interval. So just there is prolonged PR interval, that is type 1 first degree heart block. Here also you can see the same. See here, bifid P wave, I think it is from V1, because in V1 it is bifid. You can see here, okay, this is type 1 block, PR interval. Okay, whenever there is bradyarrhythmia, you should see the PR interval. Okay, remember. Then type 1 is wenkebach. I said vice versa, sorry. So type 1 is in secondary AV block, it is type 1, it is also known as wenkebach. There is progressive PR prolongation until a P wave is not conducted. Okay, see here the P wave where it is there, it is close to the QRS complex, the distance is increasing, and here there is dropped beat. Okay, again here see the P wave distance is increasing, PR intervals is increasing. Here again this P wave is followed by a dropped QRS complex. So PR interval gradually it prolongs and it is followed by a dropped beat, that I mean followed by a dropped QRS complex. So that is nothing but a second degree AV block. So it is of 4:3 type, meaning after every 4 complexes you are having a dropped QRS complex. After every 3 complexes you are having a after every 4 P waves you are having a dropped QRS complexes. Again this is also same, you can see here the PR interval, see it is increasing, again it is increasing. Now here you are having a dropped QRS complex. The PR interval progressively prolongs until there is a failure of conduction falling. So remember this, like this second degree type 1 block is something, it is giving a warning signal. it can be regarded as a warning signal, because in second degree type 2 Mobitz type, there will be no progressive prolongation of PR interval, just there will be drop it at any site. Okay, this type 1 and type 2, sorry, type 2 is you can type 1 in second degree is also a warning signal, but you can remember this as orange signal. You can see in traffic, no, orange signal. This is a orange signal to your car to stop. So then which is the red signal? So this second degree type 2 Mobitz type block is the red signal. That means you should intervene here. You should intervene, otherwise it will progress to, definitely it will progress to third block. So there is sudden failure of conduction without any PCD prolongation. This PCD PR prolongation is nothing but the warning signal. Now it is not giving any warning signal only, just it is dropping the QRS complex. So it is more dangerous than type 1 second degree type 1 block. So this is a red signal and this is a orange signal, just to remember. Okay, so after red signal, if you don't intervene, then it is going to progress to third degree block. In third degree AV block, there is AV dissociation again. You can see here there is no prolongation in PR interval, but here you can see a drop beat. So no warning signal. I am dropping a beat. No warning signal. No warning signal, and I am dropping a beat. And I will go to this third degree if you don't intervene. This is a red signal. Okay. What is third degree? Complete AV dissociation. Atria and ventricles beat independently. See the P waves and the intervals between the P waves, they are same, and these are the ventricles, and the interval between the ventricles are same. So they are beating at their own pace. There is AV dissociation. So AV dissociation is also seen in this third degree AV block. Okay, but the rate is reduced. That's how you differentiate between ventricular tachycardia and third degree AV block. Third degree block, you will have reduced conduction rate, and in ventricular tachycardia you will have more than 100 beats per minute. There is AV dissociation. See here also. Okay, there is complete dissociation. The atrial rate is 80 and ventricular rate is 38. Because atria, the impulses from the atria are not conducted to the ventricles, so they start. I said in the basics class, every cell of this heart has a pacemaker potential. SA node generates the impulses very fast. That's why it will become the boss and main pacemaker. But at some time, if it ceases or if the impulses don't go downside, then they will start beating at their own pace. Okay, that you can see. So here, see, this is the P wave. Okay, this is the P wave. There is no relation between this. This is the P wave. This is the P wave, and this is the QRS complex. This is the QRS complex. This is the QRS complex. Okay. Atrial activity does not conduct to the ventricles, and there is a regular escape rhythm of 35 beats per minute. So the ventricular rhythm which is coming, that is known as escape rhythm. Now just we will discuss about the clinical features and investigations, and tomorrow or in the next video we will discuss how to approach in detail with a flow chart in case of narrow complex tachycardia and broad complex tachycardia. Symptoms are highly variable and depend on the ventricular rate. It depends upon the ventricular rate, duration of arrhythmia, presence of underlying heart disease, and individual patient sensitivity. Remember these things. So these are the clinical features they present. They can present with palpitations, dizziness, chest discomfort, ischemia, dyspnea, pre-syncope, syncope. So these are the cardinal manifestations of arrhythmia: palpitations, dizziness, CNS, heart, ischemia, chest discomfort, lungs, dyspnea, pre-syncope, CNS again, pre-syncope and syncope. Now some specific characteristic of these tachycardias. SVT often these are often paroxysmal with sudden onset and offset. Sudden onset and offset, paroxysmal, commonly seen in younger patients with normal hearts. Normal hearts, younger patients, sudden onset, offset, paroxysmal. Atrial fibrillation and atrial flutter are common in older patients with hypertension or structural heart disease, and they carry a risk of thromboembolic stroke and tachycardia-induced cardiomyopathy. They carry risk of stroke and tachycardia-induced cardiomyopathy and stroke. So atrial fibrillation and atrial flutter are seen in older patients who have a structural heart disease or hypertension, and these SVTs are usually common in young individuals, paroxysmal, sudden onset and offset. Okay, normal hearts, abnormal hearts, atrial fibrillation, atrial flutter, hypertension, and they carry a risk of stroke and tachycardia-induced cardiomyopathy. VT can be asymptomatic, as in, for example in non-sustained ventricular tachycardia, or it can cause severe symptoms like syncope and sudden cardiac arrest also. Sustained VT is a medical emergency. Okay, polymorphic ventricular tachycardia, nothing but Torsades de Pointes, is unstable. Sustained VT is emergency, and polymorphic ventricular tachycardia, nothing but Torsades de Pointes, is unstable. So what is the drug of choice for this? The drug of choice for this is magnesium sulfate, IV magnesium sulfate. So for bradyarrhythmias, what are the symptoms? So there is decreased output, cardiac output. So fatigue, lethargy, exercise intolerance, decreased blood supply to the brain, cognitive impairment or syncope, also known as Stokes-Adams attacks. So how do you diagnose? So this is systematic analysis. Two-lead ECG during the arrhythmia is the cornerstone of diagnosis. During the arrhythmia, remember. Okay. How you do see the ECG? Systematic. First, assess the rate, whether it is tachy or brady. Then you see the QRS complex, whether it is narrow or wide. Narrow implies SVT, wide complexes imply VT or SVT with aberrancy. VT or SVT with aberrancy. Okay, that's one. And third, you assess the regularity, regular or irregular. Then fourth, you look for P waves. This is systematic analysis, very important, very important, very important. Very easy, you can diagnose an arrhythmia like this. Okay, so you are seeing the rate, morphology of QRS complex, regularity, and then you are looking for P waves, whether they are present or not. If they are present, what is their morphology and what is the axis? What is the relationship between the P waves and QRS complex? If there is a relationship, if every P wave is followed by a QRS complex, then it is AV association. And if they are beating there at their own pace, they don't have any relation, that is dissociation. So you should see whether there is a presence or absence of P waves. If they are present, what is their morphology? Okay, and what is the axis, and what is the relationship between relationship with their QRS complexes. And the last one is analyze the RP interval. This RP interval is important because it helps us to distinguish between AVNRT, AVRT and atrial tachycardia. How you see here? See, RP is nothing but this R to this P. This is typical. From the peak of the R wave to the peak of the S wave, you measure the distance, that is RP interval. So here the S wave presents as pseudo R, as we have learned, no, in the previous 90% of the cases. It will be like absent P waves, or it will present as R dash in the V1 lead. Okay, so you measure the distance with RP interval. Okay, RP interval. So here it presents as R dash or no P wave. So this is typical AVNRT, as we have learned before in the previous video. Now see here, this is a short RP, but again this is a short RP which is following a QRS complex. Following a QRS complex, there is short RP interval, that is AVRT, and this is utilizing a fast pathway, nothing but WPW syndrome. Fast pathway means accessory pathway it is utilizing. So when it is like that, when the P wave is after the QRS complex, this is AVRT utilizing the fast pathway. And if the P wave is back to the QRS complex, in other words, if the RP interval is long, short RP interval implies AVRT, fast pathway. And why it is like this? Because it is like this in short RP. Why short RP? Okay, this is the accessory pathway, this is fast pathway. So here there will be antidromic conduction. This will go and the conduction from will be from here also and from here also. So from here there will be a QRS complex, but immediately after this will go and hit the atrium just after the ventricles are activated. That's why there is a P wave here, that is AVRT, which is utilizing the fast pathway. The circuit will be like this. This is the accessory muscle, this is a SA node, AV node, this is the circuit. When the circuit is like this in accessory, so this pattern you will see. Short RP you will see in AVRT. Okay, long RP nothing but, or in other words, P wave is behind the QRS complex, then it is atypical AVRT, as we have seen, or AVRT slow pathway. What is slow pathway? Now this accessory pathway will act as a slow pathway. Here the accessory pathway was acting as a fast pathway. Here in this the accessory pathway will act as a slow pathway. So what happens after the activation of ventricles by the normal impulse? This will take time to reach the what do you call? No, sorry, I am here. So it is activated in this manner only. But it is utilizing the slow pathway now. So it will take time to activate the ventricles. Okay. So that's why the P wave is far away from the QRS complex. That's why there is long RP. Here this accessory pathway is acting a fast pathway. That's why immediate P wave. Here the accessory pathway is acting as a slow pathway. That's why far QRS complex. So AVRT slow pathway or atypical AVNRT, or it can be atrial tachycardia also. Why? The P waves are different and QRS complexes are short. Okay, QRS complexes are short. Okay, then coming to the last thing, what are the tests? 12 lead resting ECG is the first line test. Look for evidence of underlying heart disease like MI or any hypertrophy or any pre-excitation, nothing but WPW syndrome, slurred QRS complex with reduced PR interval, channelopathies like Brugada pattern. What is Brugada pattern? You will have elevated ST segment in V1, V2 and V3. Long QT syndrome, QT prolongation. Okay, QT prolongation. So any electrical disturbance or any structural heart disturbance if you find in the ECG, then you should refer the patient for 2D echo. Now, if the arrhythmias are not frequent, and one more point, I just click this picture in your, keep this picture in your mind. Okay, this is important picture. Keep this picture in your mind. Short RP is seen in only AVR fast pathway, and this is narrow complex. Okay, and in long RP is seen in three things: atypical AVNRT, AVRT slow pathway, and atrial tachycardia. So anything, any abnormality and P waves and that to and QRS complexes are narrow, so that is nothing but SVT. The treatment is same for all this. Okay, ambulatory ECG monitoring. So for frequent daily symptoms, you can take Holter monitor, and for infrequent symptoms, you can have loop recorder. It can be patient activated or auto triggered, external or implantable. Implantable is the choice. Okay. Third is exercise stress testing to provoke exercise induced arrhythmias, assess the QT interval response. Fourth is echocardiography, essential to evaluate for structural heart disease, LV function, hypertrophy, valvular disease. Invasive electrophysiology study, EPS, the gold standard for diagnosing complex arrhythmias. Catheters record intracardiac signals, allows for precise mapping of arrhythmia circuits, and testing with programmed electrical stimulation, often combined with curative ablation. Okay, so this is the gold standard. EPS, electrophysiological study, invasive. Okay, these are the tests. So in the coming class we will finish off this topic. We will meet in the next video. Thank you for listening.